All right, folks, good evening. So, I'm Dr. Lance King. I'm a family physician at Warren Clinic. This is Dr. Brent Dennis. He's an internal medicine physician at Warren Clinic and also the chief medical officer of Warren Clinic.
Good evening.
Also with us, we have Mr. Brian Almond, who's the senior MyChart consultant with Epic, and I would be remiss if I didn't point out Tess Westhoff, who pretty much runs these shows. So thank you, Tess, for putting this together. And thank you guys for being here. How many of you have actually attended a medical town hall in the past? Okay, great. Nice. So that's really good to know.
Some high expectations for us now. So.
Okay. And this is my first time, so you guys set me straight if I don't quite get it like you want it to be. How many of you have physicians that are part of Warren Clinic? Great, good. How many of you have heard of Marcus Welby? For those of you who weren't born in the middle of the last century, like me and others, this guy was everything to every patient. He was an incredible communicator. He had, probably 2 patients a week. He would sit there in the kitchen and help you figure out all of life's problems. He would drive in the car with you and find your lost pet. I mean, it was almost too much. That's right. But I think it gave us a template or a vision of how should a physician and a patient interact, because this guy knew his patients and he had gained their trust and he had gained their appreciation. And I think that's what Dr. Dennis and I want all of the Warren Clinic physicians to do on your behalf, because that's kind of why we're here. We are here as physicians to take care of you, and we can't take care of you if we're not thinking about you in the highest possible way. So at the end of this presentation, I hope that you will have a greater understanding of some of the challenges for physicians. We can have some give and take and maybe understand some of the challenges for you as you enter into your visits with your doctors. So I think it's just a great time to have a good conversation and to learn from each other. We also could possibly change the title of this because it's sort of archaic and a little bit misleading. How to talk to your physician. Maybe a better title would be how to communicate with your healthcare team, because increasingly Dr. Dennis and I and the rest of the physicians depend on our team. I'm sorry, I can't be Marcus Welby. I can't hang out in your kitchen. There's too many things otherwise going on. I need the advanced practitioners. That's the PA and nurse practitioner. I need the pharmacist. I need the social worker. I need all of these other people who are important members of the team to help me do a better job. And oftentimes they're more ably equipped to do their aspects of the job than I am. So before we get into that, though, let's talk a little bit about who are we in terms of St. Francis Health System. We're just a big old place, and we have many moving parts. But one thing that we have is our mission. And our mission is to extend the presence and healing ministry of Christ in all that we do. We have our values, and our values are really important to us. And here's, you've seen them before, they're posted everywhere. We take them seriously. Excellence, it's kind of assumed, I think, when you go to the doctor that person is a good doctor, that they know what they're doing, that they are experienced, that they're capable. But what about dignity and justice and integrity and stewardship? These are things that also are important in Warren Clinic and in St. Francis Health System to ensure that you're treated, no matter what your status, as a very important person. And hopefully that's what you experience as you go through our health system. And Brent, do you have any comments about the importance of the values?
I do. I think you've been here for 40 years. Did we just have that anniversary?
Yeah.
Okay, so
This
congratulations on 40 years. I'm just a young 22 years here, but I think with 60 plus combined years, we've seen a tremendous amount of change. When I drive up Yale and I look at the hospital and just think about what it was when I moved to Tulsa 22 years ago, it's pretty overwhelming. But what I appreciate that hasn't changed is that mission statement for the hospital. And as we are recruiting new physicians, one of the things we'll tell them at their first interview is that we are a nonprofit regional hospital committed to Tulsa and mission driven. And if they can't align with that mission, they're probably not going to be happy here. But I think if they can, you find folks like Dr. King and myself who really enjoy practice in that environment because it lets us treat patients the way that we want to be treated.
Thank you, Brent. In addition to our philosophical unity, we also have what is oftentimes known as a vertically integrated health system, meaning we want to cover the entire spectrum of medical services and health for our patients. And that requires a lot of entities, a lot of structures. Right here, you're in St. Francis Hospital. It's St. Francis Yale, as we call it. Part of St. Francis Yale includes the Children's Hospital and the Heart Hospital. Up the hill is the Laureate Psychiatric Hospital and Clinics. We have the St. Francis Cancer Center out at 51st towards Garnett. We have St. Francis South at 91st and 169, which is undergoing a tremendous amount of growth right now. They're essentially doubling the size of that hospital, as are they working on St. Francis in Muskogee. We have St. Francis Hospital in Veneta, and we have St. Francis in Glenpool, and most recently, St. Francis in Owasso. All of that has Warren Clinic physicians embedded in those structures. And so Warren Clinic physicians, how many do we have now, Brent? 400 and something?
We have about 450. We should have about 467 once all the new ones come on board here over the next year, plus another 200 plus nurse practitioners.
Yes. So
spread in 114 sites now.
114 sites in I think 10 or 11 different communities. I mean, obviously there's Tulsa, Broken Arrow, Owasso, Sand Springs, Glenpool, Bixby, the surrounding towns. God, I hope I didn't forget one. Somebody will be here from one of the surrounding towns. But yes, Jinx. Thank you. There it is.
Right.
And then the other communities that were listed. And McAllister. We have a Warren Clinic in McAllister. So we are really the eastern half of the state. We don't need to go to Elk City. We don't need to go to Kansas. But we want to be present in this part of the state. This is where I need a little bit of input from you. I hope that by the end of this that we'll have a better understanding of how to prepare for the visit, or for maybe it's not a visit you need after all. Maybe it's a different way of communicating and getting your questions answered from your physician. We want to make sure that you understand the constraints of time for our physicians and how to make the best use of the time that you have with your physician or provider. We need to acknowledge that it's difficult to navigate, not only wayfind in these big old places, but to navigate the complexity of, okay, what am I supposed to do with that visit? What does that mean? Where are we going here? And so I'm wondering if there's other hot topics that this group wants to make sure that we cover in our discussion tonight. I'll open it up for any of those kind of comments if there are any.
Okay. I've got one comment.
Yes, sir.
You mentioned constraints of time. How about getting some of the physicians to show up on time for the appointments?
That's an excellent comment.
It is.
I think that's something we should cover tonight. So thank you for saying that, because everybody's time is valuable. It kind of embarrasses me, and I'm sure it does Dr. Dennis, when occasionally a doctor will say, well, I can't see you if you're more than 15 minutes late. It's like, oh my gosh, how often are doctors 15 minutes late? You know, it's not fair. Well said.
I think we had a question over here.
Yes.
Yes, ma'am.
Question tomorrow, I have a video that they got for really the physicians doing that.
Yes.
My heart,
Yes.
Yes,
Almost
we're-
all of us are.
We're going to talk about that a little bit more as well. I think
It's a great tool.
you're in the right place. We're gonna go into that a little bit.
Brent, would you
One more question.
Oh yeah, go for it.
about the referral system.
Okay.
Okay.
Takes 9 months to get
To see some specialties.
Mm-hmm.
Yes. That's on our agenda to talk about, but thank you for pointing that out. And that's part of the whole situation where, as all of us age, I mean, I was born in 1953, you can do the arithmetic on that, and you know, nobody's getting any younger, right? And so how many times have we heard in the office, well, I didn't used to take any medicines, and now look at me, I'm on all this double handful of medicines you give me. And it's because as we age, our health needs more support, and that requires more medical care, that requires more Marcus Welby's or whatever their more modern proxy is. So it's that's part of the thing, but it's disturbing, isn't it, when you really need something or you're in pain and the referral center says, well, we'll try to get to you this year.
I think we have
Brent, would you-
one more in the back,
Yeah.
and then we'll move on.
Yeah.
Okay.
Yes, and we have a whole slide on that, but thank you for pointing that out. The involvement of family members, proxy access, privacy, these are issues that I think we should discuss tonight.
So I think we're going to touch on each one of those things. Hold us to that, though. If we
Yeah.
miss that, we'll
Don't let us forget that.
come back. Yes.
And then, how do you want to be communicated with now? Because I know everybody's moving to my chart, or
Right.
physicians have smaller EMRs that they're using. Do you want us to come in with a list of questions, or do you want those electronically submitted to you through the app? And then do you read those, or is it the NA that's reading them?
Good question. Yeah. I think you'll hear the answer is yes and yes.
Both
But
yes and all.
But we're going to walk through a visit and how you get that information in front of the physician most efficiently for you and for the physician, so that information gets where it needs to be.
Brent, it sounds like what we imagined we
think
should
so.
talk about is so far in alignment with some of the questions.
All right. Let's
Would
jump
you-
into it.
Would you give a couple of sentences on, you know, you and I spend a lot of time working with physicians and trying to improve their communication, their timeliness, their ability to do a better job for you. Tell us a little bit about how that works from a leadership perspective.
Well, what Lance hadn't told you is he has served in my role in the past and still serves as one of our medical directors for our newer physicians, particularly as they onboard. But an important part of our role is to work particularly with those newer physicians coming in. We've got some smart younger physicians who've had amazing training, but sometimes you don't learn, how to manage an office. You may know how to manage sepsis, but sometimes how do you stay on time is not always intuitive. And so oftentimes that requires, how do you work a team of people efficiently in the office? How do you answer phone calls efficiently? How do you work with patients to make sure you're answering questions, and when is it time to schedule another follow-up visit? So that's not always intuitive. We're very purposeful when a new physician comes on board. We have over 30 new physicians coming on board this year, so that's a big challenge to visit with them, see how they're doing, see how their schedulers are building, and help them build the right amount of time that they have so that they can learn that cadence and make sure you don't feel rushed and make sure they don't get frustrated. And then for our older physicians, we have continuing education programs for them, not only about the educational topics that have to do with their area of expertise, but oftentimes it's on communication skills, about how to listen, about how to be about how to really understand where your patients are coming from, about the things that we're missing. So it's a very purposeful education that we're both involved in, that I enjoy because I can teach them my mistakes. I see some of my former patients here that could probably, wag a finger at me about some things I've done or if I've been late and so on. But it does give you an opportunity to say, well, when I face that situation, this is how I handle it. Or this is what I use with the computer so that I'm more efficient and I can look at the patient instead of having my nose in the computer.
So I love being a primary care doctor. I really do. I can't think of anything I would rather do in life. And I also want to make sure that our newer physicians, as they come along, can see the joyful aspects of it, because there really are so many. And, younger doctors sometimes get tired and frustrated and burned out, and we just want to do everything we can to reduce that phenomenon. Well, let's jump into it. So here's Madge, I guess we'll call her. And, maybe she's Dr. Marcus Welby's telephone person. But let's talk about the telephone, shall we? 100 years ago, if you wanted to go have a medical visit, you would probably call your doctor's office. I mean, that was the way it has been done literally for decades. And so now we have to ask ourselves, well, my toe hurts. I think I better go see the doctor. That would be our primary way of thinking about that. But in reality, maybe what we need to do is communicate with our healthcare team to figure out what is best, what's the most efficient use of their time and our time to properly and accurately, least expensively, solve that problem. And so if we do that, it might call for sending a MyChart message first. My toe hurts, what do you think I should do? That's fair. And then the office might say, I don't know, why don't you schedule an appointment? Which, okay, well, at least you're doing the right thing at that point. It's not like a guessing game. Or you already know for sure you want to go ahead and be seen because your toe hurts and you have a whole list of other things you want to talk about.
Lance, I'm curious how many are on MyChart or familiar with that as we talk about that? Almost everybody. Okay. So if you're not on MyChart, that is a communication tool through the computer or through your phone where you can have those electronic messages that go back and forth to your doctor, that you can see a record of the note from your doctor's visit. We'll be talking more about MyChart, but we do have MyChart experts here, so if you're not on that, it really is a helpful communication tool. Take some time this evening and they can help you get hooked up with that.
That'd be Brian.
Brian.
So...
yes, ma'am. If you send the message. So the MyChart messages are meant to be non-urgent messages. So if you're having chest pain, you'll say, call 911. We all hate that recording. I hate that recording, but at the same time, it's right. If you're having crushing chest pain, the best place to be is in the emergency room. If you're having an acute issue, the telephone is the way to get to the doctor the fastest, so they can help you figure out, do you need to be coming straight into the office? Maybe you do need the emergency room. But the MyChart is more for those non-urgent messages. So it's, the on-call doctor is not looking at those at night, and on the weekend, most of us do look at them on the weekend, but if we're at a family occasion, we may not. They're not triaged that same way a phone call would. So it depends on the urgency of that message. And so for messages that can be answered the next work day or usually within 48 hours, that's usually a good MyChart option. If it's something you need to know right now, it's a good question. That's a phone call.
Yeah. Lance? So you can call the office. That's fine. That still works. But as you know, you got to listen to the long recording. If this is an emergency, hang up and dial 911, and then it gets into this and that and the other. Then eventually a human will answer the phone, and we're in clinic, we want to do a better job at that. Sometimes we do a great job, sometimes it could be better. But for some of you folks, the best way is just to call the office, and that's fine and that's fair. Another way is just to schedule your own office visit on MyChart. There's an option to do that, and there'll be some specific advice about that. If you're having a follow-up visit, it's always best to schedule that as you leave so that you don't have to have any uncertainty about, now, when was I supposed to come back? I better call the office and see. Also, for referrals, it's really a good idea if you see your healthcare provider, whether it's the physician or the advanced practitioner, and they say, hey, I'm going to send you to the dermatologist or whatever, then it's really good to get the referral center's phone number, and because some of us don't necessarily answer our phone, when somebody we don't know is calling, and you can call them directly and set up your own appointment. It takes some of the wait and see out of that whole process. By the way, we'll put this number out there, but the referral center's number is 918-488-6688. And if you're one of my patients and I see some familiar faces out here, you've seen me jot that down on a card.
We might take just a second and talk about what the referral center does.
Yeah.
And so, we remember days when I would come out of a room and I would tell my nurse, well, this patient needs to see the cardiologist and the dermatologist, and we need a stress test, and we need a colonoscopy, and see me in 3 months. And that nice part, it was fast for the doctor, but it was hard to make all those things happen. And so your
Right.
nurse is sitting on the phone, calling and trying to talk to each office. So we centralized that, and the referral center knows your insurance, and they know which doctors are available, and they know who's able to see you the fastest, and so they're just our coordination tool there. So if you call on a referral that's been placed, oftentimes we are deferring to them because they're that intermediary. So if it's about a referral, going directly to the referral center is often the fastest way to get an answer on that.
And all of our Warren Clinic physicians participate in the referral center, and then the referral center can also help make referrals to non-Warren Clinic physicians for the most part. Did you have a question?
Could you repeat that referral?
Yes, thank you. 918-488-6688. And so when you call, so if your doctor makes a referral and, we're all out there talking fast and say, I'm going to send you to Dr. so-and-so, he's a general surgeon, and make sure they call you, or you can call them. Well, you don't have to know even who we made the referral to. You just know that you have a referral. You need to know your name, and then you call the referral center and tell them your name, and they will help you sort through that. So it's pretty smooth. It's very helpful. Let's talk about the different types of office visits. And most of you all may know this, but primary care is internal medicine, family medicine, pediatrics, and to some extent obstetrics and gynecology. The specialties are the specialties. For primary care visits, you're going to come in either for a wellness visit or a follow-up visit or an acute problem visit, or perhaps, hope not, a after hospitalization visit. For specialty visits, kind of the same. You're either going in as a new patient, or you're going in because you're having a follow-up with your specialist, or you're going in because you had surgery, or you're getting ready to have surgery, or some other procedure. So does that make sense to everybody? That's pretty self-explanatory. What may not be completely explanatory is, for our purposes, there's different time allotments for these visits, and there's different complexity to it, and our sense of preparation for these has to be appropriate so that we devote the right amount of time for each type of visit. Let's talk about my chart for a minute, and then Dr. Dennis is going to talk about some more details here. But we've learned that just about everybody here has my chart. Goodness, when this rolled out in 2014, it was the most amazing thing. Let me tell you what it was like in a medical office before my chart. You would always call the office, because that was the only way. Somebody would take down your message. Your message might be fairly complicated. Then that little piece of paper would be shipped from the front of the office to the back of the office. It would land on somebody's desk, kind of in a stack. And then if the office on their game, they would say, oh my gosh, this is a really important message, versus just ending up in the stack. And then the office in the back office would sort through those. Maybe it's needing referral, maybe it's needing an appointment, maybe it's answering a medical question. but a refill, but it all was on paper and the telephone, just like 100 years ago. Then when we introduced Epic and this patient portal, it was life-changing for a lot of us. Because with MyChart, I see those messages myself, and I see them all day, and I answer them, as they come through. It's you saying, "Hey, Dr. King, I think," and I'm reading it and dealing with it and answering you back. Some of you, if you're my patient, you've seen me answer that at 10 o'clock on a Sunday night or 9 o'clock on a Saturday night. I mean, yeah, that's the life I live, but that's okay because I can get to those things when I can get to them, and sometimes I choose to do that, in the off hours. As Dr. Dennis was saying, this is not for acute emergencies or really hot topics. You need to call, or you need to go to urgent care, you need to go to the emergency room, you need to do something other than just send a message. And I'll give you an example of that in a moment. I would encourage you, as you write your MyChart messages, if you're going to message me something, I have a guy, and I don't see him here tonight, but he always writes in caps. And that's fine. And he's also that guy who seems to be kind of yelling, so it sort of fits, but he's not really yelling. But, I mean, that's fine. You could do that if you want to, but it's not necessary to yell at me. "Thanks, Dr. King. I'm glad that it's like, wow, he's kind of hot on that." Mm-hmm. MyChart messages are going to be there. They're not written in stone because they are a digital thing, but occasionally it's like texting. Sometimes we're sort of hot under the collar and we say something and think, that was kind of hot. I wish I hadn't have said that. Well, if you send that in a MyChart, it's there forever. So just keep that in mind as you decide whether you're going to really tell us what you think.
Before you tell us what you think of that doctor that you saw last week on MyChart, but you're really going to go back and see her again? It's a part of your permanent medical record. So that's something that you just need to be aware of, that's in there, and legally we can't take that out.
I think too much drama in a MyChart message is, it misses the interpretation of that. I am dying. I've been dying all day, and if something doesn't happen soon, I'm going to die. Yeah. I literally don't know what to do with that message other than see if they need us to call 911, because how would you not? But sometimes people are using some hyperbole in their messages.
And that's usually the one you get on Sunday night when you log on.
Yeah.
And you're trying to figure out, Mrs. Jones, are you okay?
Yeah. You just got
if the message was there on Friday.
You got to answer them. Make sure that if it's a business office topic, that probably goes to the business office, because bear in mind, MyChart messages are pretty much coming to me or the other medical type people. So, there are billing issues and questions of that nature, and that is probably not so much a MyChart thing, but I guess it could be. Let me give you my hospital patient example. Last weekend, I didn't look at this message. It came in on a Friday or on a Sunday night, and the guy said, "Well, I'm bleeding, and I just don't know what to do. And what do you think?" And it actually didn't go to me. It went to one of my colleagues, one of the consultants on his case, and I didn't see it till the next morning. And, that's not a MyChart message. That's go get some help right now. And that's what ended up happening, because, there's a kind of a cruel statement that says all bleeding stops eventually. So, he ended up in the emergency room and got transfused, and then he's still, I guess after he got some blood, he's sending MyChart messages to me and to all kinds of people. "Well, I guess I won't be there today because I'm in the hospital bleeding." I mean, that guy is a MyChart extraordinaire, but that might not be the exact way that it's supposed to be used. Somebody mentioned, what about family members? We see that all the time when somebody in the family will say, "Hey, it's Josephine and Joe's having this problem, I mean, make sure you have MyChart proxy access for that, and you know, I guess we can talk about how that works here in a moment. I'm going to turn it over to Dr. Dennis for a few minutes. He's going to talk about some other virtual options for the office. And Brent, I didn't talk about Care Companion or Track My Health.
Okay, we'll talk about that. I'm
But
going to
trade you
key
places.
off of that MyChart proxy. I take care of an elderly parent, and that's our best friend because we've assigned a proxy. We can communicate with my father's physician. We can send concerns because I'm not sure he's going to say them when he goes into the office, but he doesn't always want us there in the office with him because doctors are nosy. And so, you know, having that, if you take care of a loved one or someone that's under your responsibility, great opportunity for you. Once they give you permission, that you can share information with the physician, and you can see where they've been referred, and you can see their lab results and results. So oftentimes it helps, particularly if you have a memory impaired loved one. So it's a great opportunity. But let's say that regular office visit is not serving your needs. We're going to talk for just a minute about some of the newer virtual options, and we asked about that a moment ago. So you're going to be prepared for this virtual visit. Okay, you're going to be an expert at this. So a little bit of a history of the virtual visits. A few years ago, this was before COVID, probably about 3 years before COVID, we had this great concept of doing these virtual visits, telephone or video visits on an iPad or a computer. A few hospitals in the country were doing that, and so we went around trying to talk our doctors into, we have patients that live rural and can't come in. This is a great option. Everybody's like, I'm not going to mess with that. I'm going to do the video. And then, of course, COVID hit, and COVID, we want to keep contact with people, and overnight we just lost that. We had to close the offices, and suddenly what became kind of this quirky thing that we might be able to do became the lifeblood of how to keep in contact with those we're trying to take care of and for you to see your doctor. So I would guess most people during COVID had the opportunity to become acquainted with the virtual visit. One of the things we were committed to was making sure that those virtual visits were a connection for you to be with your physician and not a way to outsource you somewhere else. And so I will tell you personally, in my practice, it was a lifesaver for me to in my mood to be able to get on and see patients in that virtual. And I put on here virtual house calls because to me it's a positive that way. I got to know family pets that I never met before. I got to see people's homes. It was great when they needed to show me a medication because they had the bottles right there that we forget to bring to the office. So it's always nice to see people coming back in the office, but there's some really good things we learned about virtual visits. And so that is something we are now taking from the COVID experience and figure out where does that live today as one of the multiple ways that we can keep good communication with the patient. I think about school teachers, some of our most dedicated group. They cannot leave the classroom to come to an office visit. So being able to connect with them between a class, when they can do that in privacy. For someone who's homebound, being able to connect with them virtually when they can't come into the office and you can still talk to them. So those are great opportunities. There are sometimes we say, and sometimes on a virtual visit, Lance, I'm sure you'd say, I think I need to have you come into the office. I need to push on your belly. I need to just see you in person. But many things now we've learned to take care of. And I love that sound. That means a baby's being born. You hear that? Okay. If you didn't know that, that's great. Yeah, that plays anytime you hear that. So we have the virtual visit, which is the connection with your physician using your phone or using the computer. If you're not familiar with this and you're intimidated for the first time, we have a virtual health coordinator who can help give you a test visit. You can talk to the office and say you're having trouble with that. They can set you up with her and let you hook up your equipment and make sure everything's working okay. But it's become much more simple than it was 3 years ago. Now the office will send you a notice. When you get that on your phone, you just accept that, and it puts you into your MyChart, at which time you can, it'll bring you right into a virtual waiting room where the nurse and the doctor will talk to you there. So don't be intimidated by it. We have staff that are here to help with that. If you're curious about it tonight, our MyChart staff can show you where that function is. But also, if you want to do that trial, we'll get you with our virtual health coordinator to do that. We also have a virtual urgent care. care, because many times these things happen after the office closes. Our virtual urgent care is staffed in the evenings by our physicians at Springer Urgent Care. So Springer Urgent Care has been here for a very long time, has a great reputation. Dr. Davis and her crew are excellent. So they are actually boss. If you after hours say, I need a virtual visit and can't wait for Dr. King tomorrow, that's likely who you'll connect with. Now, occasionally we let Dr. Davis sleep. So when she goes home at 8 or 9 o'clock in the evening, then our emergency room doctors will take calls that happen during the 2 o'clock or 3 o'clock in the morning hours. But that is something that's available to you and available on your insurance for something where maybe you don't need to go in to be seen, but you do need to talk to a physician tonight and get a better idea of the right way to treat your problem. I'm going to take just a minute and talk about some things that are not office visits, but maybe alternatives to an office visit or a virtual visit. The first one is an e-visit. Has anybody in here done an e-visit before? Okay. All right. So not many. So we'll talk about this. So an e-visit also has its place. It's not for most conditions, but sometimes there are very simple type of things that maybe you don't need to talk to the doctor face to face about, but you need treated. Maybe you need a medicine for it. A perfect example would be you got a nasty bug bite that went bad. And so there's an e-visit for bites. You can go on there and you take a picture of your bite and you describe what bit you, and was this a snake or a spider, and then you send that picture to the doctor, and then that doctor is, as Lance was saying, when you're coming out between visits, he'll say, oh, Susie sent me an e-visit. I can look at that real quick before I go in the next room, and then they'll send a message back. And whenever you are on break at work, you say, oh, I got my message back, and it says, well, we sent an antibiotic in for that bite. It looks like it's getting infected. So it works real nicely, what we call asynchronous. You're not talking to the doctor at the same time, but you're getting that message back and forth and at a time that is convenient for both of you. An e-visit, we try to have that turned around within 4 hours. So if our doctor is busy, that actually goes over to poor Dr. Davis and her crew at the urgent care too, and they answer that if the doctor can't get to it, unless you specify this needs to wait until Dr. King is available. So that's an e-visit. An e-consult is different, and this is not something that you would initiate, but this is something your doctor would initiate on your behalf. And it goes back to what was asked a moment ago about the difficulty we have sometimes with referrals and consultations. We need more doctors in this state, and then in some specialties we could use a lot more of those specialties. And so, as you know, if you've tried to get into a neurologist or you've tried to get into a rheumatologist, sometimes those waits are tremendous. And it used to be that we could send you to Oklahoma City or we could send you to Little Rock, and now the waits there can be just about as long. And I've certainly been on the side of that too, as a caregiver for family members with those problems. It's a frustrating wait. So our approach to that is multifaceted, but and we can go into that more later as we have time, but certainly we recruit to have those specialties available. We work with ways to make sure that the patients that need to get into the office the fastest can do so, but one of the ways we do that is with an e-consult. And so as a primary care physician, if I have someone come in my office and I have a question about a rheumatology problem, that this patient is on their Plaquenil for their connective tissue disease, and they've got 6 months before they see their rheumatologist again, and they're not doing well, I have the ability to send that rheumatologist an e-consult electronically and say, is there something we can do now that I can do as a primary care doctor to treat to help you have more time to see that new patient instead of someone that maybe you just need to give me quick advice on. And it helps us work more efficiently to open up access to that specialist. But if you have a question for a specialist that they can answer to your primary care doctor and allow you to remain under the treatment of your primary care doctor, that's the role of the e-consult. So that a little confusing there, and I'm open to questions on if we have it, but we're seeing more and more areas where that's popular. We have a Mohs surgeon dermatologist who does this very well. If you come to my office and I don't know what that mole is, I can take a picture of it, I can send it over to him, and he's going to say, I'll see him tomorrow. Instead of the 4-week wait, or you should know what that is. You went to medical school. Put some steroid on it. It's fine. So there are some easy ones like that. Psychiatry does a great job on this. We've been through these 3 medications. It's not working. working, they'll say, well, why don't you do this combination? I think this is the place to go next, and can avoid that long wait to see a specialist. One more I'll mention before I turn it back over to Lance, and that's Dispatch Health. This is something new for us. Dispatch is a company we partnered with to provide some care services at home. So the purpose for this would be something that's an urgent, almost ER, but maybe not quite ER needed, but you need help this evening, you can't wait for the visit tomorrow. Dispatch Health has a couple of vehicles that are equipped with lab, an x-ray, a nurse practitioner, and access to an emergency doctor that nurse practitioner can reach out to. You can call them directly, or you can have the office send them out, and they can come to your home and assess you to oftentimes provide an antibiotic treatment, or to make a referral for you if something is needed, to check a wound or something there, to avoid that emergency room trip if it's something that maybe doesn't need to be in the emergency room.
I had a patient yesterday, Brent, who, an 84-year-old lady who, I mean, nobody wants to go back to the hospital. And so she had been out of the hospital for 2 or 3 weeks, and she called the office, said, I can't breathe very well, and she was checking her own oxygenation. It wasn't bad, and there wasn't anything terrible about it. She says, I don't want to come to the office, and I don't want to go to the emergency room. I mean, I try to spoil my patients. I want them to be happy with what we do. So I said, well, how about we send Dispatch Health out? And I'm surprised she didn't say, how come you don't just come on over? Because
Marcus Welby would have.
that would be called a house call, which I've done many years ago, but I can't do a chest x-ray. Well, Dispatch Health went out, they did a chest x-ray. This lady needed to go to the hospital, but with the additional information and with what happened, she's fine, but she's in the hospital now. Also on the e-consult, and I don't know how many hundreds of pictures I've taken, photographs in the office of skin lesions, and sent them to the dermatologist. Because as Dr. Dennis pointed out, there are so few dermatologists and certain other specialties being made. We just don't have enough people to do that. Our dermatology department is exactly 2 physicians right now, and they have, I think, 4 advanced practitioners that work with them. But to get a photo of the lesion, instead of just trying to, it's a red, raised, crusty bump. That doesn't tell you as much as here's the photo. And the photos that we can take through MyChart are very crisp, very accurate. They're also private. It's not me taking a picture of it on my phone. It's taken through a Epic MyChart protected device. What's the right word for that?
It's a HIPAA protected
Brian?
environment.
It's protected. And so that allows, good way for that patient to move up to the front of the line if that's what's necessary. Okay, well, any questions about what Dr. Dennis said before we move on to some more specifics? Yes, sir. Well, thank you for saying that. That's what we want. That's exactly what we're searching for. We want to be one of the best health systems in the nation. I mean, that's kind of a bold statement, but that's not in our mission statement, but that is exactly what Dr. Dennis and I and other people in leadership want for Warren Clinic. And it takes being bold enough to try on things sometimes that don't work out. But so far, so good. Was there another question? Yes, sir.
Prior to COVID, if she had someone call her, she couldn't charge for it. Well, during COVID, they changed that.
Yep.
So I assume you may be going to cover it, but are y'all able to charge for these various items? Because Staying in business means making a little money.
Right.
That's right.
Well,
And-
I'll address that. You
Go
know, before, and that's probably the reason I had a hard time selling that. The only way we could charge for video was in certain circumstances. If someone lived in a rural area, they went to a specific place to do a video visit, and then they're connected with the physician in a different area. What happened during COVID is they changed what's called an originating site rule. So instead of you needing to go to this clinic where I have my TV set up, you can do it anywhere you have a phone. And that opened the window for us to connect to patients in a convenient way, where before it really wasn't all that convenient. And so that is something that has to be addressed at the national level to maintain the ability to that charge. But right now, both sides of Congress are in favor of that. They've pushed legislation out a couple of years that allows us to continue to be able to charge for that in a similar manner that we would for the office visit, because everybody has really liked it, and I think nobody's against that. So yes, that was not a possibility before, but it looks like for the foreseeable future that will continue to be something that can go towards insurance.
And insurance is covered.
Insurance covers
Yep.
that, yes.
All of them do.
Yep.
Okay, so let's talk about preparing for the office visit. This is where y'all are on. We have our responsibilities. We have what we need to do to make sure that the visit is right, and then it's kind of a dance. So you have responsibilities as well. And so most of this y'all already know, but I mean, where is that doctor? Okay, well, figure that out so you know where you're going. You know, there's the Warren Tower, there's the Warren Clinic building over on the other side of Yale, there's the Kelly building, the William building, there's, you know, on, but, you know, kind of figure that out so that you can make sure that you're at the right place at the right time and so forth. What are you supposed to bring? You know, should I bring my blood pressure log? Should I bring my blood sugar log? Should I bring my neighbor? You know, should I bring all my family? I mean, try to think through those things as you decide on what kind of visit is this. You know, make sure that you try to be on time. And to this gentleman's comment, you know, if you're on time, that helps us stay on time. And there are many other elements to that I get at. Make sure that your family members, if that appeals to you, have MyChart proxy. And that's a thing that you sign that lets them get into your medical record and send messages for you. And I think that should be reciprocated within families if that's what you're going to do. But I think that's very helpful for everybody if that's done.
I think we had one question on that.
Oh, yeah. I don't see who it is, but where are we?
Thank you. Is that same authorization that the patient gives to the wife, the same authorization to use my chart as a proxy? Or is it, or do I need a different authorization to get into my husband's chart?
Can you answer that, Brian? Go ahead.
So if you actually have your own MyChart account already, you can actually just invite your husband or spouse or adult child or whoever to have access, as long as they also have a St. Francis MyChart account. You can do it electronically, and it's done over email. Very simple, might take 5 minutes.
So one thing that's going to happen increasingly, and I think for most of you it's already happening, is you get pinged before the visit with, hey, would you like to have digital registration for your visit? Usually a couple of days before the visit. What a great time to go ahead and fill out those forms, otherwise they're going to hand you a clipboard in the office, and then you have to grumble a little bit about, don't they already know that I'm allergic to sulfa? Don't y'all have that in your giant machine somewhere? We should, but you know, if you do the digital registration, it's just smoother.
I'll tell you one of the fun things about that, and when you've done that at home, and we track how much time this is, when you go to that front window in the office, that poor PSR who's answering phone calls, answers about referrals, trying to process the paperwork, each time we take something off the load, they have more time to talk to you, and
Yeah.
they have more time to enjoy their job, and we're more likely to keep them there, and they have more time to be personable. And so sometimes the things that we can pull out and make electronic and do before the visit allow PSRs to be PSRs, and allow nurses to be nurses, and allow doctors to enjoy that face-to-face contact.
I think it's also a great time to, you know, is it called a list? Is it called a patient agenda? I don't know, but I love it when my patients will send me by my chart something that says, hey, Dr. King, I'm going to be seeing you tomorrow, and by the way, I want to cover ding, 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 ding. It gives me a preview of what they have in their expectations, what I can sort of have in mind. It's just helpful. So think about sending your agenda parentheses list ahead of time. Yes, ma'am.
You know, when you have a healthcare team and one physician of the team enters something into my chart that you got backward. You got back. Okay. You don't want to blast it all in my chart. Hey, Dr. Cody's got this.
Yeah.
Yeah.
What would be a proper way to handle this? Because I thought I handled it properly, and I still have not had a response.
I might answer that. So that can be, there's two different variations of that. One of them is where they reviewed my note, and this happened to me this week, and somebody sent me a MyChart message, and they said, Dr. King, I know that you said I'm tired, but I'm really not. I'm fatigued. And I just called her and I said, look, thank you for reading your note, and I'm gonna make some corrections here, but just to be clear, those are kind of synonyms, and tell me more about which, we worked it out. But I think what you're getting at is you came to see me and you had fatigue, but you also had a sore toe, and nothing was said about your toe. It just went by. Is that your question? No. Okay.
Right. So if you had a cancer on one side and the doctor said it was on the other.
I bruise easily, bleed easily, and just turn around and say, does not.
Right. Okay. So I think it's great that we can read those notes now, because back in the paper charts we had no idea what was in there and what the consultant saw. So it's meant to be there for your protection to read that. So the first line of those sort of things is to be able to just tell the office so that physician can go back and addend the record so it appropriately reflects a medical condition. Now, if you're one of those people that sends 20 different things about every little, my dog's name is Fred, not, whatever,
Yeah.
that gets old. But if it's something that's important medically, it needs to be changed in the record. Sometimes that has insurance reasons. It could affect your health down the road. Within a certain amount of time, the physician can go back and amend that record themselves, and that's always a good place to start. If this is something that you find that was from 90 days ago, that record's been closed or it's not happening, we also have a department that works with our legal department and called Documentation Integrity, and we would submit a request to them and say, this is incorrect, this needs to go back and change, and they can help make that happen. So, yeah.
So, and I didn't want it to blast all of
Gotcha.
my chart.
Sure.
So what I did was I privately put my concerns in a sealed envelope, and I just took it over and I said, "Would you put this in this physician's office?" And all I asked there was, "This was my concern. Please contact me."
Yeah.
That was super polite of
That
you
is a
to
great
do it
way to
that
handle
But I don't care if somebody sends me a message, and it happens just a couple of times a year, saying, I think you got that wrong, and this is the way this is what I believe it should have been. That doesn't hurt my feelings. But what you did was extra nice.
And if you're not hearing something from that, we can talk afterwards and we can get you with the director of that office to take care of it. Okay.
So family member involvement. Has anybody here ever asked a family member to attend their office visit with them? I think most of us have. And there's usually a really good reason for that, isn't there? It's because, you just had surgery and you need help getting in and out. It's because Joe can't hear worth a darn, and Mary Lou needs to be with him so that we can all figure this out together. Sometimes people have dementia. Sometimes there are other reasons to have a family member. I am happy that a family member joins the patient in the office. I am unhappy when the entire family joins the patient in the office. So the magic number there is 1. Yes, sir?
I'm probably your worst patient. I probably am. If he didn't go with me, I've never had any problem in my life.
Yeah, I'm fine.
I say, well, last week you were sick all day.
Yeah, no, I'm fine. Yeah, that one. I got it. So if there's more than one person, our little tiny rooms can't handle that. Family systems are such that, you know, the two siblings are in there and pretty soon they're getting into it or disagreeing in front of me and it gets awkward. So just think about who is your family representative that you would like to have in there. And sometimes it is appropriate to have the spouse and one of the adult children in there, and we'll manage it. But everybody needs to be on their best behavior.
Yeah, exactly. And that sometimes includes answering for your family member. That was oftentimes when we may ask questions, knowing they may, you know, particularly if they're memory impaired, they may not know the answer to, that may be wrong, but we still are kind of using it to gauge where they're coming from. And we want to hear that wrong answer rather than have you answer for them. So just be aware in that part of the exam that usually the physician will train to be focused on the patient, and then they may turn to you and you know, expect you, okay, now tell me what really happened, or your spouse in the same case. So just to be aware sometimes that there's a tendency to answer for our spouse or answer for somebody else, and it makes it a little harder for the physician to judge where they're coming from.
I don't care. I mean, maybe I'm more open to these things, but somebody will say, hey, my daughter's in Colorado. I'm just going to go ahead and get her on the visit here. I mean, if that's their phone, if that's what they want to do, I'm open to that. If they say, I'm going to go ahead and record this entire visit just so I can play it back, and that kind of creeps me out a little bit, but I don't think that's...
My attorney loves to listen to these.
Okay, yeah. But it's not an absolute hard no, but I would want to hear about it beforehand. I don't want to be being recorded under the table. Any questions about family involvement? In general, it's a good thing if it's necessary. Bring a
have
list.
one question coming
Oh,
through.
yeah, sorry.
The MyChart proxy situation, is that different than a signed HIPAA release?
Yes.
Okay.
You need to specifically give them proxy to get on there, and you'll also do the HIPAA release in the office, but you need to have the specific release for that electronic access.
So if you want a partnership with a family member, you really need to have
Both.
in place.
Right.
The proxy is specific so that they can get on your MyChart. So let's talk about lists. I mean, I love lists because, oh my gosh, some of our doctors used to say, I'm only going to see people with no more than 3 problems, and you know maybe they're younger or more set in their ways. But you know, in my leadership role, I say that is not fair to your patient, and you know you need to really think about that. I mean, the human mind can only deal with about 3 things anyway, so 3 is a good number, and it's way better than 13. But you know, sometimes there's a lot to talk about. And so you have to recognize, back to our comments on what is the nature of this visit, we can't cover an encyclopedia of concerns in any one visit. It's not written in the Bible that you can't come back for those other concerns. You know, that lets everybody sort of take a breath and work through it, because the more problems after a handful we get into, the less capable we are of really dealing with them. And so you have to recognize our human limitations, and you know, the human mind, the doctor's ability to handle 13 different problems it's not going to be very good. Prioritize your list. I mean, what are the most important things to you? Send your list to me. I'll help you sort through it. Me being whoever your doctor is that you're going to see. And then we want you to be empowered to ask your questions. If there's not a list, then you haven't had a chance to engage yourself in why am I taking Jardiance? I mean, you know, ask your questions, have your list. I think that's helpful for all of us. It also gives you a chance to clarify some discrepancies. And, you know, a lot of us use dictation to create our office notes. And we call them dragonisms because our machine is called Dragon. And pretty soon just some total nonsense is being spit out and put on the page. And unless my eye is really careful to see that, if you see it later, if it doesn't make sense to you, it's nonsense. And you can help us clarify it later on, but dragonisms are a thing. Do you have any comments about that, Brent?
I'd say I always like it when someone would, circle the one thing on the list that is most important to them today. Because as physicians, we may look through a list and we've got a different prioritization process. We're saying, okay, what could be a red flag of something really worrisome? But that may not be what is worrisome to you. Mm-hmm. And so it's helpful sometimes to know, this is what's really important. And to us, we're thinking we're doing a good job medically picking out the things that may be most urgent to address. But to a patient, it may feel like, well, they're skipping over the things I'm concerned about. So as he said, help us prioritize and at least circle that one thing. If nothing else were addressed, what is that one thing I really need to know leaving today?
Because we have a list too, and we're pretty goal-oriented. We're going to get to our list. If you have diabetes, your doctor's going to say, now, have you seen the eye doctor? How do your feet feel? When was your last A1C? Do you have your blood sugar? We're going to get to our list. But in our eagerness to solve our list, we don't want to leave your concerns out.
There's a question in the back.
Yes.
So my question is, because I learned it from experience the hard way, is there ever an opportunity to ask your physician a question and say, this is off the record? Meaning like it doesn't go in the chart, and I'm going to, so for example,
I don't want this written down, but I'm using marijuana at night to help me sleep. I hear that all the time. And, oh my gosh.
Yes.
Yeah. And so
because what I like about the town hall forum and who I came, when you say have that good relationship with your PCP, well, years ago, I was diagnosed as a diabetic, I'm insulin dependent, it says in my charts, and guess what? Now I can't get long-term care insurance. And so I said to my primary care, I was like, nobody wants to come in here and tell you anything because it becomes a part of our record.
yeah.
Untrue, and now it causes problems down the road.
I think if it's clinically relevant to have documented, then you'll say, every time I walk upstairs, I have this horrible chest pain, but I don't want anybody to know it because I'm trying to get insurance. I'm making this up. I have to write that down because that could be a life and death thing. My toenails turn blue at night sometimes, and I don't want to write that down because, my loved ones might read that. I don't have to write that down. So it depends. But if somebody asks to have something not written down, I think it's a case-by-case thing. What do you think?
I would just add that when the life insurance companies and they're pretty smart now, so they're not going to necessarily read all my dictation. They have computers that are going to say, "Oh, I see that blood sugar was elevated. Oh, I see that medicine they're on." So they have these lists of folks. One of the problems we have right now is a lot of people taking diabetes medications for weight loss that are not diabetic, and so everybody, the computers think they're diabetic. So it's not necessarily the notes that's going to call you out if it's in there. If it's true, it's probably already out in the information that's there. But there are times in which your information can be protected. I've had patients who are in an abusive situation at home, and they're kind of forced to have that. That someone's going to look over their shoulder and see their note, and they don't. And if they want to share that in confidence, sometimes we may say it's better not to have it in the record. Or other times we can do something called a break the glass, where even with the proxy, you can't get in there, or other family members can't get in there. We do have some extra levels of protection if there is a dangerous situation there, and there are certainly circumstances where that needs to be taken advantage of.
Because now, fast forward all these years, and I'm feeling, super cranky and want to have that relationship with my PCP, right? And I'm thinking, well, if I express this, and now next thing you know, I'm going down that mental health,
Right.
And so I'm just like, can I go to him and say, can we knock this off the record? Like, I just.
I think that's an interesting question. And to reiterate what Brent said, we have a way, like if there's a domestic situation where it could be dangerous for somebody to come across what was revealed, we put that in a separate zone. And we also are sort of compelled to say, do we need to call call in some help for you.
Right. And you mentioned mood or that, that sort of thing. If you go to Laureate, their records will be protected that way. If you're talking to a psychiatrist, they have that level of protection automatically with those records. But if you're in a similar type of sensitive information area with one of your other specialists, your primary care physician, talk to them about how I can secure that record. And if they don't know, they know how to get a hold of us, and we can tell them how to do that.
So somebody the other day I'm talking about Dr. Google now. Oh, yeah, go ahead.
Could you specifically say, I want this excluded from my healthcare proxy so it can't be looked at?
Can you exclude it from your healthcare proxy, Brian?
Yes, you can. You can actually request of your provider to not release a note to MyChart. Your providers do have that option on a case-by-case basis.
Okay, good to know. I didn't know that. Okay, so this lady the other day came in, and she had poison ivy. She'd been out at the lake, and she had poison ivy. But she brought in her information, it was on her phone, about lichen planus, which is, it's a thing, it's a rashy thing. And she had convinced herself that she had lichen planus, and, good for her. And then we got on her phone, and, I can't see very well, and it was just on and on. And so it kind of became a funny thing for me, because I said, it's poison ivy. He says, well, how do you know for sure? I says, well,
It's the
I
40
just
years.
know what I know. And if it doesn't get better with what we do, we'll talk some more. Maybe it's lichen planus, but I think it's so important for patients to be informed. And I think what you're really trying to do there when you start looking stuff up is to relieve your own anxiety or get ready for the big bomb. And so I encourage people to look stuff up. I discourage people from buying it hook, line, and sinker. Let me vote as well on what the diagnosis is before you go off the lichen planus zone, because that's the opposite of relieving anxiety. It stirs up anxiety, and it's always good to have informed patients. And if you're going to show it to me or to your physician, how do I put this gently without seeming egotistical? You're probably not going to teach me anything I don't already know from Google. But it's sweet, the patient says, Dr. King, did you know that there are plants that can make you have a rash? And I'm like, did not know that. Tell me more. So it's good to, offer a copy of it, and I'm not sure what I'll do with that, but okay, thanks. But ultimately, the point of looking stuff up is to give yourself some orientation about what the spectrum of possibilities might be, and give a chance to relieve your own anxiety. But let us help you relieve your anxiety as well.
I would just add to that, your physician, there are good sites and bad sites. Google's bad because it's going to put advertisers to the top, which are usually trying to sell you something or scare you into buying something. Ask your physician, what sites are good for me to look at? And there are some great search engines out there that you can use for study, and they can point you to sites like Medline Plus and others that have good vetted type sources for medical information if you like to get on the internet and study.
I work with a nurse practitioner in my office, and it's a sign of success when I pop the door open and, say hi to the patient, and they say, "Oh, Dr. King, it's just you. I thought I was going to see Anya today." Some of my patients are over here saying, "Yeah," but we work as a team, and so all of the Warren Clinic physicians eventually, I believe, will be working with advanced practitioners. They are better at doing their role than I am, and that's why they're there. So they're there to help me and to help the patient to decide which things they should take care of. They are sometimes more available. I mean, I may not be able to see the person till next week. The nurse practitioner can see them tomorrow, et cetera. So I would encourage you to the extent you can, accept that in the future, it's going to be the team. It's not going to be just Marcus Welby, it's going to be the team. And the team is actually better suited to take great care of you if everybody's doing their part. Some of us, I talk to people all the time, usually guys, who say, I say, what did the cardiologist say? Because I already know because I have it in my thing in front of me, but I want their interpretation of it. I say, well, I haven't seen the cardiologist and I don't know how long I have to see his helper. And, that gives me a chance to kind of educate them about, well, actually, that's probably because they're more suited for helping manage that problem than maybe would be the cardiologist who's over there poking something sharp into somebody. So if you need the cardiologist, maybe it's not such a great thing instead of their nurse practitioner. Have y'all had experiences with nurse practitioners and advanced practitioners, PAs? Yeah. Yeah. And they know when to stop and say, hang on, I'm going to go get the doctor. And so we teach our people not to overextend their level of expertise. And so I think that works really well.
It's important for you to know, too, that as we bring these team members on, that we're, again, purposeful in training and making sure they're prepared for the position that they're going to be in. So for some of our specialties like cardiology, urology, that nurse practitioner, once they finish training, may spend 6 months in a mentorship with other nurse practitioners before they're seeing someone on their own after training, just on the job here. We do something similar. I know our dermatologist has a great crew of PAs. They spend every Saturday morning doing training sessions for months before they're seeing patients on their own. We challenge our primary care physicians to regularly sit with their nurse practitioners and review what's working and what's not working to make sure that they're working as a team and comfortable asking questions and making sure they're working together on that. So it should never be, okay, we want you to see Joe, the PA over here because I've got an early tea time. What we see now is with medical care, in a typical primary care office, there's an hour of paperwork and additional type of work that we do outside of an hour of patient contact time, and we didn't have that 20 years ago. And so somewhere we've got to leverage that time where the physician and the nurse practitioner, PA, everyone can be where they're most efficient.
So wrapping this part up, there's our buddy again, right? And that's what I want to be in my mind. I want to be all the good things about him without, sitting around in your kitchen drinking coffee endlessly. I want to have great communication skills, and I want all of our physicians to have great communication skills. I want them to have great clinical skills. I want them to be really good at what they do, and it's up to primarily Dr. Dennis and a little bit to me to ensure that our physicians deliver on that. I want our staff to be outstanding. I love it when the front office person, because I can overhear things, somebody walks up and they call them by name. Mm-hmm. Say, Faith will say, well, hello, Julie, how are you? To me, that just makes it so much better. I want to be available. That requires, the extension of me with the rest of the team, because some problems just can't wait. Even in your mind, if they can't wait, you get to define your dis-ease. And if you are uncomfortable waiting, then we want to see you as soon as possible. And I think that goes to one of our values of dignity. We want to make sure that you feel like that you're being treated with the appropriate dignity. So Dr. Dennis is going to talk to us now about that guy was the past. Let's hear about some things in the future.
Okay, and we'll make this quick. I know we're at the end of the time. We want to have time for questions and for you to challenge us for the things we forgot to address. Just a quick note on the future, because these are some exciting things we're constantly looking at. Well, what's it going to look like in a 1 year, 5 years, 10 years down the road? Anybody watch the Jetsons? A few Jetsons out there? Okay, I watched the reruns, okay? So, but I enjoy the Jetsons as a child. But I remember what seeing the doctor was like on the Jetsons. You sit at the breakfast table, your throat's sore, you want to skip school, and they turn around and suddenly the doctor is on the television. It's amazing to me. We've got that. I mean, we're there. We don't have we don't have our cars flying around like they did then, but we got that part right. So that's kind of fun. But I think one thing I know we're going to see is right now, it would probably take you about 20 minutes and your breakfast would be getting stale at that point. But we're going to get faster and faster on being able to have virtual access. So you need something, you connect with us. It'll probably a nurse practitioner that can see you or get you to the doctor in a virtual visit where you can get that answered before you go to work. And so that's not the remote future, that's coming. E-check-in from home is there now. We talked about that earlier, where you come up to the office or you do a kiosk in the waiting room and you don't need to sit in the waiting room. In fact, many people are saying we won't have waiting rooms. You'll check in online, you'll come up and say, oh, Mrs. Jones, you're here, go on back to room 10. And then you'll go back there and see the nurse, and there won't be any of that, reruns on the television in the waiting room and old magazines. So that's exciting. One thing I want you to be aware, because some of your physicians will be piloting that, and that's an AI technology called ambient listening. And Dr. King mentioned Dragon, which is how you've seen your physicians dictate and record voice. This is with the same company, but it's a device that lets us record the visit, and it understands the different voices and the multiple voices in the room and can create the note, because it knows what kind of note we want out of our conversation. So I don't ever dictate. I come out of the room and my note is ready, and I just go through and edit the note. And the idea is here, when that happens, instead of my eyes being at the computer and typing, I'm having a normal conversation with you. And this is creating that note off of the conversation instead of me having my attention to drawing the note. So a lot of hospitals that are kind of on the front edge of doing this now, this is still pretty new, are seeing their physicians are happier in their job and patients are much happier when the physicians are looking up. So we have 10 physicians that are starting that pilot now, including Dr. King, and we'll have 25 more added on here in the next couple of months to a second part of that pilot. And I'm thankful Warren Clinic gives us an opportunity to not only practice the kind of medicine we've done in 20 and 40 years, but also give us the new technology to kind of stay on the front edge of some of these things as well. So that makes it fun to practice, but ideally it's about recreating that time one-on-one with the patient. So we're going to take a moment here. We do have the MyChart team here. They've already answered some questions. Also want to make sure that we address the earlier questions that came up. I believe we did most of those as we went through.
Let's see.
Anything
help us remember what we've forgotten in the questions, or maybe there's other questions.
Any other questions this evening?
Wait times, it doesn't fit with our values of all that, but I mean, you can kind of get it if the doctor's running late. I think we owe it to you to alert you. Somebody can pop in and say, oh my gosh, the doctor's running late. I went to the dentist one time and I was sitting out there and sitting out there and sitting out there, and finally I went and tapped on the little window and said, did they forget me? And I've been to my dentist for a long time, and she said, Dr. King, it's been 5 minutes. So, it seemed like forever.
That's enough for you.
And sometimes, it's shameful how long sometimes people have to wait. It literally makes me ashamed that we can let that happen. Not in my office, but I know it happens. And so, any advice on that?
I will add one thing here. We do look at, you're constantly surveyed, and you're asked things about wait time and how happy you're with your provider. We look at those really closely. In fact, some of how we compensate physicians is based on not only how well, it's not just coming to the office visit, how many people do you see, it's how well did you take care of their diabetes, how well did you take care of their blood pressure, how well did you listen to them. And so those things we put our money where our mouth is, and we're not perfect on that, and I'm sure we could all share the dentist stories, but it is something that we emphasize, and that's part of your job, is to take care of patients in a way that's value oriented. So we continue to emphasize that and incentivize physicians to do just that. I think we had a question here in the red shirt.
I was wondering, is there a certain age where you make, say, cardiologists retire? Because you had a cardiologist here at St. Francis, and I loved him, and I trusted him, and I heard that he had to retire because of his age.
There's not, when people are doing surgery in the hospital, there are national guidelines on that, and people who do surgery generally don't do surgery after age about 75. And I'm not sure we want our heart surgeon to be doing heart surgery on us if they're 78. I mean, it's just, you can be president or somebody in the Senate, but for people that are doing stuff with their hands, I'm just not sure. For the ambulatory physicians, we have a number of our physicians that are well into their 70s. I can think of one guy who's 82 who rides his bike to his office there in Muskogee every day. So that's kind of a long answer, but no, not exactly. But then if they're a surgeon or somebody who's doing technical things, then they have to pass other tests.
Yes, I think the red shirt, you had a question.
Is my chart specific to hospitals only or to certain clinics? Let's say a person was on a trip, and they go to a hospital elsewhere. How do they access the information?
Great. My chart is part of the Epic system, which we use for our electronic health record. If you go across the world, the majority of health care records are on Epic. I think at one point I saw 60. We've got to be higher than that percentage in the United States right now. So there's a good chance whatever your hospital that you're going to is also on our same electronic medical record. And what that means is that they can get access to the records here, which is great from a medication list and a medical history. It's a huge safety factor, and I think physicians all enjoy that availability. You can also, on your MyChart, choose to share your information with other organizations who may not be with that, so you can use that to share. Now, if you were to be in a hospital in Honolulu and you wanted to be able to see your records from there, their system can give you Epic access on that as well. And many hospitals, including some pilots we're doing in the hospital here, have a whole part of my chart that's about your hospitalization. So you can see day to day, where am I going to the MRI? Sometimes order your food off your my chart, and what's on my care plan for the day. Anything you want to add to that?
We have a thing called Care Everywhere, which I use that all the time. Mm-hmm. My patient is down at MD Anderson or some other hospital system that uses Epic. Then that information just flows to me every day. It's great. On the other hand, even in Tulsa, we're Warren Clinic. All of Warren Clinic is on Epic/MyChart. But then some of the gastroenterologists, some of the orthopedic doctors, there's certain non-Warren Clinic physicians, but who practice at St. Francis, who are simply not using that particular electronic medical record, and that creates a problem sometimes.
Yes?
I'm sort of blown away with what you have presented here. I had the country doctor concept in my mind. Isn't it appropriate then to ask your doctor, is he part of this organization? Because it's like having a vast array of opportunities to support you.
Yeah. Well, we have every physician that we have, all the 450 of them, have access to these tools. And so, whether you're in McAllister or Veneta or across the street, we want all of our physicians to have those tools. So, if you go to, I've had patients come in before and ask on a referral, are they on my chart? Because I kind of like seeing my notes and I like to see my X-ray results. And I wouldn't have guessed that would happen, but they wanted me to refer them to another doctor that has that my chart just so they can see that information. And they like the communication back to me as a primary care physician that happens when they see that tool.
But I think it's important to me to know that my doctor can see all that.
That's fair to ask. Yep, it can be. Yes.
The nurse practitioner and the physician's assistant, what's their difference in capabilities?
Can you address
So
that?
it depends on lots of factors, but essentially they're identical. So their training is different. A nurse practitioner has been an RN for several years, and then they decide to get their master's degree in being a clinician. And so their background is such. A PA is somebody who has a college degree who decides to go to PA school. Dr. Dennis and I, attended medical school at a time when the PA students were right there with the medical students in the first couple of years, learning biochemistry and anatomy and such. And so once they have their formal training and their licensure, it kind of depends on what they want to do and what their supervising physician wants them to do. For example, as Dr. Dennis was pointing out, if they're over in the dermatology clinic, man, they better get ready because they're going to have hundreds of hours of additional training on dermatology based on what's required there. In a primary care office or in urgent care or some of the other settings, they've kind of already got the skills. They need some supervised clinical experience, and so gradually they learn that. And does that answer your question?
Yep.
They're interchangeable.
Yep. Yes, sir.
Ambient listening, I'd like to ask a question.
Yes, sir.
That's a recording, I assume. I assume.
Yes, it is. It is.
Anything to do with artificial intelligence?
It very much does. Go ahead.
No, part of part A. Part B is, when is that recording restored?
So that recording, contractually, they typically destroy that at 7 days to allow time for editing of that, but we don't keep those recordings in the background for a lot of different safety and liability reasons. I think there's a lot of benefit to safety in having that initial recording because if I'm, at 9 o'clock at night and the, kids have gone to bed and I'm sitting down and finishing my dictations, I may not remember that visit as well as I think I did. But but when you've got that direct AI-driven translation of your visit, then it's pulling out exactly what the patient said, and it takes a lot of that human factor out. I still have to go in and edit that, but it certainly improves that. But at the same time, that information is private. Once it's created into a note, we don't need that electronic format that is deleted.
I'm using the DAX. I'm part of the pilot, and so when I go in the room, I don't use it for every patient, but if it seems appropriate, I say, they have signed a release, and then I confirm that with them. I say, no, I'm going to use this DAX technology, and most people say, sure, I don't care. I said, it helps me not sit here and type while we're talking. And so I'm kind of fascinated with how very precise that information is that ends up in the record. So I think I like it. I'm not 100% sold.
Richard Hoare is one of our nuance experts here. I see in the audience. Do you recall if that's 5 days or 7 days? You may not.
It depends on the phase that you're in.
Mm-hmm.
I think early on, most of the time, and they do keep those recordings for a certain number of days.
Yeah.
And then as it is artificial intelligence, so as the system gets better at working with each individual doctor and learns how they talk and the words that they use, then the performance increases and then you keep those recordings very long. The technology is advancing so quickly. I really wouldn't be surprised that in the next 2 to 3 years that there would even be a recording. So it really is, and it's such a time saver. This dovetails with what a lot of the questions, how do you help your doctor stay on time and see you at your scheduled time, but also allow the patient before you that extra time to talk about one thing that I forgot I even want to talk about, but now I'm here, right? And they're trying to do both. The way that you can give your doctor more time to visit the patients is have them spend less time talking. So, it's a good thing, and I think it has a lot of promise.
Well put, Richard. Thank you.
Dr. Dennis, I don't know that some people want to stay past the
No?
allotted time.
You probably need to go home and do dictations, right?
Yeah, my gosh, I got to get to my charts.
Answer my chart messages?
But I really appreciate this conversation. I feel like, we've talked about this. We used to do this where we had patient focus groups to sort of learn more from one another. And I don't know, we've got your names. You may get invited to do some of that.
There we go.
But thank you for being with us. And before we part company, are there any other questions that people feel like they want to make sure they ask, or you can always come up here afterward? Yes, ma'am. Go ahead.
Okay.
It's I don't think so.
Yeah,
I think
no,
it's,
they're open nights and weekends. They're open night and weekends. I think there is a time like at 11 or 12 once they
Yeah.
close. But there are times you may tell them this is the concern, and you do need an ambulance. But for most things, even if it requires drawing blood, doing some X-rays, they can do that in the home. Community care covers that. I think Blue Cross Blue Shield, United, most of the insurances are
Medicare.
covering that in the home now. Okay. You can't, now, a lot of times if you call the physician's office during the day, our physician's offices have been trained, if they feel that's appropriate, that they can send them out on your behalf. You can call the dispatch company directly. They've got a website, and I think I wrote that number down earlier. That's over here, but I can get that for you later. But you can go to Dispatch Health Tulsa and call the number and reach them directly. Okay, we're going to let you go, but we'll be around for questions afterwards.
Yeah.
I see so many of my former patients. You better come say hi. It's exciting to see you, so thank you for being here.
thank you. Thank you.